And every time I'm on the highway, I feel terrified because there's like lunatics passing me on the Mass Pike at 100 miles an hour on both sides, just zipping by.
Chris.
Because there's nothing to stop you.
Chris, I have apologized to you several times. Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am by TikTok. Do you guys use TikTok?
Never.
Oh, one of my kids loves TikTok.
Exactly, and so do mine.
Yeah.
I don't get it, and I recognize that I must sound like, your typical old guy when I say this, but I just don't get the fascination.
What my daughter loves to do is there's these videos of the kids where they like do dances, right? And then they send each other, they're like doing dances to these short clips of songs. And I think that's the way she uses it most. She's 12.
Yeah.
But I know it's cute. Like they're all doing their hand gestures and they're waving and they're doing, and it's like 30 seconds and they send it to each other.
Yeah.
So I don't know. I think the Chinese eat your heart out on tween dances.
I get it. I do get that, but I can't see how people spend hours and hours on it. But
yeah.
Anyway, I am Matt Fox from the Departments of Epidemiology and Global Health at the Boston University School of Public Health, and I am here with Dr. Chris Gill. Hello, Chris.
Hey, Matthew.
From the Department of Global Health, and with Dr. Jess Liebler from the Department of Environmental Health.
Hi, Matt. Hi, Chris.
Hey, Jess.
And as a reminder to everyone, if you could go over to the Population Health Exchange website and check it out, we've got a lot of really interesting population health learning tools and programs. That's BU's hub for lifelong learning. And also, we would definitely love it if you would go out and give us a rating on your podcast app, whether it be iTunes or Stitcher or whatever it is that you use. So now on to the show. So today in our first segment, which is our Journal Club segment, we're going to look at a study on convalescent plasma and COVID-19, something that I'm quite interested in. And then in the second part of the podcast, which is our deep dive, we'll talk about masks and the potential for variolation, which I think is a mess or a bit of a controversial topic. So it'll be fun to get into that. And then in our third segment, which is our amazing and amusing, we will get into some things that make us laugh out loud or just strike our interest. So segment one, we want to talk about an article that looked at the impact of convalescent plasma on COVID, and we'll explain what that is specifically. But this one was published in Nature Medicine, and it was entitled Convalescent Plasma Treatment and Severe COVID-19, a propensity score matched control study. And that propensity score matching is going to come up for a bit. And interestingly enough, it will come up in a couple of weeks on our next episode, which was total coincidence. So that should be fun. The first author on this paper was Sean Liu of the Icahn School of Medicine at Mount Sinai in New York.
Those guys are so enthusiastic and they have such a positive attitude.
What?
They
Go ahead,
have
Chris.
that
Go ahead.
I can spirit.
Exactly.
Oh, boy. Oh, boy.
Yeah, that can-do spirit.
So I'm curious. So one thing that was interesting to me was this didn't actually get a ton of press, which really kind of surprised me. The one headline that I'll give you was from U.S. News, which said, small study supports donor plasma therapy for severe COVID-19. And maybe it's the first part of it, the small study, that answers my question, but I was a little surprised not to see more on this. But Jess, can you start off by telling us what this study was about and what they did and what they found?
Sure. So I thought this was a very interesting study. Like the two of you, I read this one with great interest. It's obviously tremendously timely, but I do think you're right. The lack of attention was probably due to the very small sample size, but that's okay. We'll go on and continue to talk about it. So as the title reflects, this is a propensity scored matched case control study looking at the effectiveness of convalescent plasma therapy on patients with severe COVID. So the enrollment here was restricted to patients who were very ill with COVID at the Mount Sinai Hospital in New York. And so convalescent plasma, that is plasma that is harvested from people who have been infected with COVID-19, and antibodies are recovered from the blood of these individuals. And then that is the treatment that is provided to patients to see if giving them basically a dose of antibodies from a patient who successfully recovers helps them recover faster or more completely. And this is actually, I'm sure Chris knows more about the background of using convalescent plasma than I do, but the authors note that this has been used successfully, this approach of using convalescent plasma has been used successfully in the early stages of figuring out the appropriate treatment for a given infection. And so they note influenza viruses and SARS, original flavor, that this also worked successfully in kind of these early phases of a new disease. But they note that it doesn't always work. For example, they noted Ebola was this was tried and did not work with Ebola. So that's the hypothesis going in, that if we harvest antibodies through plasma from patients who've recovered from COVID and then treat patients with severe COVID with this plasma, the question is, will they recover faster? And the evidence also indicates up front that the most important effects are noted in patients who were treated early with this convalescent plasma therapy rather than patients who were treated later in their course of disease. And so the authors looked at, and this I just note is Mount Sinai Hospital in New York City. The dates of this study run from patients who were admitted, incoming COVID patients who were screened upon entry from March 24th to April 8th. So this is really early in the pandemic. This is reflecting, and New York was really going through crisis peak times right at this moment, and Mount Sinai Hospital was really at the center of it. So these were researchers who were coordinating all available resources to try to look at this very astute, and it required a lot of organization on their part. And so kudos to being able to organize this on the fly as things were really going down in New York at this time. They had two core outcomes in this study. The first was looking at oxygen requirements at day 14. I'll talk a little bit about how they define baseline and the first dosing, but basically 14 days after the case patient was dosed with the plasma, and survival by May 1st. So they ended the study by May 1st. And so they were looking to see a 2-week window as it related to supplemental oxygen, and then survival by May 1st. And so incoming COVID patients were screened at Mount Sinai during a 2-week period from March 24th to April 8th to receive the plasma transfusion under the compassionate use of an investigative new drug clause through the FDA. So they applied to FDA. This is not a standard by any means procedure. This is not an approved procedure, but you could apply for compassionate use, and they did that for this research trial. 45 patients applied during this period, and 39 were approved to move forward. The average age of their participants, so the N here is small, this is, as we noted before, this was 39 patients involved in this study who were receiving the plasma. Then there's patients who will be matched to them, as we'll talk about in a minute, as controls. The average age of the patients was 55. So these might be a little bit younger than some of the severe COVID patients that we have seen later in the pandemic. They're mostly male. 2/3 of them were male. The majority of them were classified as obese with a mean BMI in their study set of a little more than 31, but they had few other comorbidities. So there were, about 20% of them had diabetes, but this was a patient population that was experiencing severe COVID, but they didn't have a lot of comorbidities other than some had diabetes and overweight. Okay. And so they were categorized, as I said, as severe or immediately life-threatening experiences with COVID. And all of the case patients were receiving supplemental oxygen. So 10% of them were mechanically ventilated, and the remaining 90% were receiving either in-room enhanced oxygen or nasal oxygen or other sorts of oxygen related treatment. Okay, so these plasma recipients, these 39 plasma recipients, these cases, were going to be matched using propensity scoring. So I'm sure Matt can talk a lot about propensity scoring and the analytical approaches as to why a team might want to do that. My best explanation of propensity scoring is that you are trying in the context of an observational study to mimic some of the elements of a randomized trial when you're not able to conduct a randomized trial. So trying to match cases and controls to a probability of experiencing the outcome at admission. So these probabilities are matched. These are the probabilities that are kind of matched between the cases and the controls to try, as an attempt to try to match confounding, to try to match confounders and be able to deal with that. Matt, did I describe that in a suitable way? Is there anything you'd want to add to that?
Yeah, no, I think you did a very nice job. I will come back to this because I think there's probably more to drill down on, and so we can sort of, but keep going with yours.
Okay. Phew. Good. All right. So they were matched using propensity scores. They took two different approaches. They matched a 1-to-2 ratio, and then they again matched a 1-to-4 ratio to try to see if they could discern anything from the additional power of adding additional controls. And they extended the range of probabilities that they included in the matching a little bit in order to do that. They were matched on baseline health risk data in terms of comorbid conditions, some baseline medical data from that day 0, including length of hospital stay up until that point, and then some additional medical data in terms of medications that had been provided to these patients, and specifically whether or not they had been intubated prior to receiving the plasma, okay? And one of the core findings also is they were matched, as I said, on supplemental oxygen requirements. Okay, so some of the findings of this study, at the end of the study, by May 1st, 12.8% of the plasma recipients had died, and 24.4% of the controls had died. So just looking at that, that's a twofold increase in death right there, looking between the plasma group and their control group. Within the plasma group, if we look at their first outcome of interest, oxygen requirements at day 14 after the initial dosing of the plasma treatment, at that day 14, 17.9% of participants in the plasma group and 28.2% of the propensity score matched controls had worse oxygen requirements at day 14 than they did at baseline. So that's showing a 14% reduction in the odds of needing or of worsening breathing conditions or of needing additional supplemental oxygen 2 weeks after the plasma treatment among the plasma group compared to the matched control group. The survival probability, this is an interesting finding and an important one, was higher among the group that was provided plasma in unadjusted models. So in their 1-to-4 matched set, the hazard ratio was 0.39. That was a just statistically significant finding, with the confidence interval going from 0.15 to 0.99. And in the 1-to-2 matched set, the hazard ratio was also less than 1, so 0.47, showing a benefit to the plasma group, a dramatic benefit, but this one was not statistically significant with the confidence interval crossing 1. Okay. In models, they did a series of adjusted models to look at incorporation of different sorts of risk factors in addition to the propensity score matching. So when they adjusted for duration of symptoms prior to admission and exposure to anticoagulation medications, which I will turn to Chris to talk in more detail about, but the authors mention a number of times, I'm myself not entirely clear on the medical rationale, but that anticoagulation medications they were concerned was going to conflict somehow biologically with the plasma treatment. So they mentioned that was a concern, and so they controlled for whether or not the patient had been provided anticoagulants and also antibiotics. In the 1-to-4 matched set, again, the hazard ratio was statistically significant at 0.34. Okay, so reflecting a 66% less likely to die during the study period among people who were provided the plasma. And then again, when they did another round of models where they adjusted for additional variables, including mechanical ventilation, use of steroids, use of antivirals, and IL-6 inhibitors, the hazard ratio was still significant in the 1-to-4 matched subset of their when they did the 1-to-4 matching. Again, and the hazard ratio here was around the same. It was 0.31, statistically significant, finding reflecting that the participants who were provided the plasma were 69% less likely to die during the study period. Okay, they note that and they did a series of subgroup analyses which had small n's, and the authors note up front that these analyses should be viewed as exploratory because of the small number of cases typically who were in these different categories. But some of the subgroup analyses did not have significant findings. They did not note a significant benefit for patients who'd been intubated, specifically comparing patients who were intubated versus not intubated. The significant effects were more upstream among patients who had been not intubated. They did not notice significant findings for patients who had presented or experienced symptoms for more than 1 week before they entered the study, before that day 0, and for those who were not receiving these anticoagulation drugs. But again, they note that these were low-powered analyses. One of the other interesting things that the authors did in this study is they looked specifically at the plasma that was provided to the participants to see if the plasma, what was the neutralizing ability of this plasma in the lab, right? So could this plasma, was there a reason to think that this plasma was going to neutralize the virus? And so they did. They were doing lots of plasma screening at Mount Sinai Hospital at the time, and they selected plasma donors with IgG titers of greater than 1 to 320 that were going to be used in this study, and they confirmed by ELISA assays that these were the appropriate donors, and there were 25 donors that were used for the 39 case patients. They looked at the correlation between the neutralization titers in the donor serum and the total IgG titers within the plasma units, and they successfully found a correlation, leading them to believe that this would make sense in terms of that this plasma would have the ability to act as they expected. But what they did not find, which was interesting, they did not notice a correlation between the donor neutralization titers, so in some ways the strength of the antibody response, and outcomes among the patients who had received that plasma. So there didn't seem to be a dose-response relationship that they observed, which is something interesting. They also noticed they did not find adverse effects with the plasma therapy. It was a small sample, but they hypothesized maybe there could be allergic reactions, that they did not see any adverse responses that they were going to tag to the plasma therapy.
Okay, so a lot going on in this study of 39 people treated with this convalescent plasma. I do want to make one comment before I turn it over to Chris, which is that you talked about the propensity score matching, and you said that, which I will come back to, but you said that they matched cases to controls, which of course is a technically a correct statement, but it does lead one to believe, as I did when I first looked at this, that this would be a case control study, which this was not a case control study. This was actually a cohort study in which cases, meaning people who got convalescent plasma, were matched to a comparison group who didn't get convalescent plasma. So not your typical case control study where the outcome is what you're comparing those who got the outcome to a matched sample of people who are representative of the study base. So it was confusing. I was going into this thinking it was a case control study when it was not. So Chris, tell us what your thoughts are on this study.
Sure. So many things, actually. It's a totally fascinating study, in my opinion. I wanted to just comment on what you were saying, though, Matt, because many moons ago in one of our prior episodes, we had a propensity score matching study. And I think you summarized it in a rather nice way, that in a propensity score, I apologize if I get this wrong, but you're matching on exposure rather than matching on outcome. And so it has different assumptions in terms of statistical power.
Yeah, I mean, so the basic idea of a propensity score is you are trying to predict who gets the exposure. You're not trying to predict it perfectly. You're trying to predict it based on all the things that you think are important confounders. And then you're trying to boil down all that confounding into a single number that you can use to summarize all of the confounding. And then you are essentially matching on one number. So you have one variable that you're matching on.
Yeah, it's a really interesting, it's sort of like, it almost feels like running the logistic regression in reverse to kind of come up with this sort of composite picture of the cases and the controls.
Yeah, a model of the exposure as opposed to the outcome.
So I have one other sort of statistical observation, which I was hoping the two of you would also comment on, which is what Jess had described how in one of the analyses, the 1 to 2 matches didn't achieve statistical significance, and the 1-to-4 matches did achieve statistical significance. And the hazard ratios or the odds ratios were practically identical. And it just seemed to me that this was such a textbook example of the advantage of having more controls. A higher control to case ratio buys you statistical power. And there it was. I was like, wait, we learned about this. And there it is,
Yeah. Yeah, the only thing I would say on that is just to clarify that it really, it's better to think of these as matching exposed to unexposed. And so you have a bigger sample size. You're likely to have more outcomes in your unexposed group than you would have in the 2-to-1 matching when you do the 4-to-1 matching. So yeah, you get more power, which confused me as to why they did all these different 2-to-1 and 4-to-1 matching. I mean, they provided a rationale, but I have to admit, I just didn't really think it was necessary.
Well, in any case, I thought this was a very nice study. I think we all wish we had a proper randomized controlled trial, and so we didn't have to have sort of tacking on asterisks, to this study result. But it is sort of an example of what is our pretest probability that this is going to work, right? And this approach, convalescent serum, stands on 150 years of experience, going all the way back to Emil von Behring in Marburg, Germany, in the the end of the 19th century, when he was intentionally inoculating horses with diphtheria toxin initially at very, very, very low concentrations, because otherwise he'd kill the horses, but escalating concentrations over time until these horses became literal factories for diphtheria antiserum. And then he would use that to treat kids with diphtheria. And it worked extremely well. And that whole sort of concept of using, antisera as a way of neutralizing different pathogens has carried all the way through the present day. And I would say that, our current focus on using monoclonal antibodies for almost anything you can imagine, there's so many applications of monoclonal antibodies, is the grandchild of this concept of convalescent serum. It's obviously not convalescent serum because the approach you take to make a monoclonal is very different from a convalescent serum, but the principle behind it is exactly the same. And then, of course, it's the same theory behind how vaccines work. So all of this makes sense, which is not to say that it's a given that it will work, because as Jess noted, it didn't work in the case of Ebola. And so, of course, there are important distinctions between different, how the host responds to different pathogens, and whether the inflammatory response is primarily an antibody-mediated one leading to control of the infection versus a cell-mediated one. And so in the case of Ebola, we now know it was mainly a cell-mediated immune response, and hence antibodies tend to not be that important. So it's not like all infections, this will work for, but for those where it is primarily an antibody-mediated response, you would expect it should work. And it did work, right? And so I look at this result and I say, okay, it's not the gold standard randomized controlled trial, and yet I'm totally persuaded by this. This is like, it just aligns with so much of what we understand about the biology of this disease and the immunology of this disease and the history of convalescent sera for all sorts of different, ranging from pneumococcal pneumonia to meningitis to diphtheria to tetanus, you have it. There are so many examples of precedent for why this result is believable. And so if I was the FDA and I was saying, we need a gold standard, we need a randomized controlled trial, in normal times, yes, that's true. In the setting of a public health emergency like this is pretty persuasive evidence, actually. So
yeah, I share your feelings that there's some good evidence here. I will say I do have some skepticism around just a couple of things. The first being the size of the study. I mean, 39 patients. I'm never
fair enough.
39 exposed subjects, so it was more than 39 people in the study. I'm never going to totally be convinced by that, particularly when it's an observational study. If you did a randomized trial in which it was 39 and 39, at least I'd feel better about the expectation of no confounding. 39 is not enough to guarantee that, but that would have been a bit nicer. I thought that the propensity score, I'm a fan of the propensity score approach. I think it's a nice way to think about creating balanced populations on things that you've measured. I had a little bit of skepticism around the fact that, so the way they did this propensity score matching was they had some data on these people. They then propensity score matched them, and then went and got additional information on them for additional confounders they wanted to control. So, they didn't control all the confounding intentionally through the propensity score matching. They also had the analytic control aspect of it. And their analytic control really didn't change the estimates at all. Now, you could say, well, they matched on the propensity score, and that really did all of the heavy lifting. And so there was nothing left over in the additional factors that they thought might be confounders to adjust for. I'm a little skeptical of that. I would have thought that there would still be some residual confounding left over. Is it enough to change my mind? Probably not on whether or not there is some effect. I'm just not sure that we know how much of an effect there really is here, given those two factors together. Jess, you have thoughts on quality of the study?
Yeah, the one thing that jumped out, one of the things that jumped out to me that the authors mentioned was the concern that the patient group that received the plasma might have benefited from more assertive, I think they were calling it assertive clinical management. So it really would take a lot of wherewithal among highly stressed providers in an emergency, public health emergency, to both be aware of ongoing trials and then to kind of, or ongoing studies, and then to kind of engage their patients. And so that was something that they tried to look at by looking at additional medications that participants were also taking in addition to the plasma. They said that there really was no distinction there. They also had a comment where they said they didn't see a difference between providing consent among patients who were in the plasma group, by different providers, which they used as a rationale for maybe that the element of assertive management was not a factor. But that was something that made me wonder, that made me think as well, in part because the hazard ratios were so dramatic. If there was anything else about the clinical management that differed between these participants and the ones who didn't receive the plasma.
If I could follow on to that, you mentioned in your narrative, Jess, that there was this sort of funny result where patients who had received anticoagulation therapy seemed to benefit more than those who, I guess, didn't. And similarly, that there was an advantage to people who received the convalescent serum earlier in their course rather than later. And I think both of those kind of dovetail into this issue of like the interaction with other therapeutics. And I'll talk about both of those and sort of cogitate about why I think that might be the case. So the second one I think is easier, which is that, in terms of treatment early versus treatment late, I think what we're starting to understand about the pathophysiology of this disease is that there's an early phase of the disease which is driven by viral replication in the tissues. And then there's a late phase, which in fact seems to be the one that kills people more often than not, which is the immunologic and physiologic sequela of that infection, which can persist long after the virus itself, the replication of the virus itself has started to damp down. And so if that's true, then it kind of does make sense that treating early with an antiviral agent like antibodies would make a lot of sense. But if you wait a week or two, it doesn't matter because it's not the virus anymore. It's all the kind of like, the coagulation, the coagulopathies and the post-infection autoimmune syndromes and the hypercoagulable states. And that is not really driven by the virus anymore. It's driven by the host response to the virus. And so that finding, again, actually kind of comports with our biological model of how this disease works. And so I thought that was a strength. So similarly, the issue about the improved benefit of convalescent plasma in the setting of patients who were receiving anticoagulants, I thought that was very interesting. And it struck me that there's two possible explanations. Well, there could be more than two, but I came up with two while pondering this. And one is that convalescent sera itself can be procoagulant. And the authors mentioned this in their introduction, that this is one of the side effects. The known side effects of convalescent sera is that it includes clotting factors, and so it can cause people to clot. And so therefore, you think, well, perhaps taking anticoagulants would counter that, possible side effect. And yet, the magnitude of this seemed large for that to really explain the effect. And I wondered, therefore, maybe the more likely second hypothesis is that this is an example of where this is an observational study, not a randomized controlled trial, and that the use of anticoagulants is a signal for patients who are doing worse. Yeah. And so, if you're doing well, you're not going to die no matter what you do. And so the convalescent serum is not going to save your life because you weren't going to die. And it's only the ones who are going to die, and those are who are more likely to die, and those are the ones who are receiving anticoagulants, where the therapy really helps them, because suddenly you're looking at that group where death was a significant outcome. I suspect it's more likely the latter. And this is sort of, a reminder that this is not an experimental design. This is an observational design, and we still run into these funny, loops of causality in trying to understand these different cofactors.
Yeah. So I what you say there, Chris, makes a lot of sense, and I suspect you're probably right. I will say though, I'm not at all convinced on the data once you start stratifying it. I mean, I've got skepticism already when you got 39 exposed subjects. When you start trying to stratify that, to me that I just tuned out when we got to that section. Sort of interesting, but not at all convincing. All right. Anyone?
So it's like the what is it? What was the name of that Milan Kundera book? The Unbearable
Lightness of Being.
Lightness of
Beings. So we have the unbearable flukiness of small data.
Okay. I feel like we talked about the unbearable lightness of being before. I feel like
it
did.
Has to do with hats and other things.
No, we talked about this because I told you the story about how I saw that movie in London and the movie was over and I got up and left, and it was later when I was talking to somebody about it that I found out that actually I left in the intermission. The movie was so long they had an intermission.
Oh, no.
Yeah.
Did you realize?
I didn't realize at the time, but I found out later when I realized I missed and I didn't get it. It seemed to end at a weird point.
Yeah, you're like that. They left a lot of threads unanswered.
They really did.
What sort of novel technique is that?
All right. Let's move on. But before we do this, just one thing I wanted to say as the last word here. There's a phrase in here that I absolutely loved. So I mentioned they did this propensity score matching, and then they additionally adjusted for factors that they went and collected data on, and they referred to those estimates. They say, when we aggressively adjusted for additional covariance.
What's that mean?
I like that's adjusting
with your boxing gloves on.
Adjusting with extreme prejudice, I think.
Yeah, they're going to use the latest version of SAS. No fooling around.
I know, no holds barred.
All right, so let's move on to our second segment where we're going to talk about a paper in the New England Journal of Medicine. This is not a data-specific paper. This is a hypothesis-type paper, which I appreciated, and I'd heard a bit about this, so I was excited to read this one. The paper was entitled Facial Masking for COVID-19, Potential for Variolation as We Await a Vaccine by Monica Gandhi and George Rutherford. And I thought this was a really interesting one. They basically, talked about some of the data around, countries where masking is regularly used and places where masks are not used. So really ecologic data, talking about the differences in the COVID-19 outbreaks. And then they talk about recent data from Boston showed that infections decreased in healthcare workers after universal masking was implemented. And so they bring up a potential explanation for what's going on, an explanation that if it were borne out would be a real benefit towards masking use. And the idea is variolation. Essentially the idea that if you are exposed to a lower dose of COVID-19, of SARS-CoV-2, that your body is going to be able to mount an immune response that it might not be able to when you are exposed to a very large dose, and therefore you may end up, essentially by being exposed to a very, very small amount, you may be able to mount an effective immune response such that you never really get sick, but you would develop antibodies. And the idea being that maybe what's going on is that masks, while they're not fully protecting people from the virus, are reducing the dose that people are exposed to when they come into contact with somebody who is shedding the virus. And that has the potential for benefits to creating a sort of semi or possibly complete immunity, which is a really interesting hypothesis, but seems to me is at this point just a hypothesis. So Chris, what are your thoughts on this? Do you find it as interesting as I do?
Yeah, I did. And I have to say, I have been thinking about this concept that they describe in their article for quite some time myself, as I imagine many ID doctors. So, we're looking for sort of a grand unification theory to explain COVID-19 disease. And it's looking like there are three vectors in that relationship. One is like the dose of the virus that you're exposed to. The second is probably the route of the virus that you're exposed to. And the third is the host status. And so in all cases, this sort of like, how does the host manage the virus is I think, the final common pathway into understanding the outcome of an exposure. And so we know, for example, that little children seem to have a lower propensity to become infected, and certainly a far lower tendency to become clinically sick if they are infected. So there's, it's the lower risk of infection, which is, a relatively modest effect, and a significant reduction in the intensity of disease, which is a much more significant effect. And then, of course, children have this propensity to develop, rarely, this multi-system inflammatory Kawasaki's-like disease afterwards, okay? So all of these probably reflect those, the intensity of the exposure and also the status of the host's innate immune system. So a young child, or young children in general, are probably going to have far more robust innate immune function than, say, an elderly person would, which means that they have a higher sort of force field, if you will, that the virus has to jump over in order to become, rooted and lead to a systemic infection. Because if the macrophages and the dendritic cells can intercept all the virus and sop it up and turn it into peptides and show it off to the T cells and the B cells, then you don't get infection. What you get is immunity. And I think this is what Gandhi and Rutherford are arguing for, that a low dose exposure can actually be beneficial. And this is for sure true, because one of the golden rules of infectious diseases is that more often than not, the size of the dose of the pathogen you receive matters a huge amount in terms of your likelihood of getting sick. And one of the best examples, sort of the best described and explained examples of that, is in how exposure to HIV virus, a different inoculum, can lead to HIV infection or to a sort of a relatively immunizing response. And so, when a virus is trapped under the foreskin after sex, for example, in a man, the viral particles are absorbed across the epithelium and encounter these antigen-presenting cells called dendritic cells, Langerhans cells. And these are kind of like the giant sort of spiderweb cells of the immune system, whose job it is to find pathogens and pull them in and digest them and turn them into peptides, and then, spritz out cascades of cytokines to the T cells and the B cells saying, "Come hither, me lads, see what I have found." This interesting thing, right? And so they do, at low concentrations, when a virus hits like the outside of a dendritic cell, that is to say, the side that's facing the mucosal surface, at a low inoculum of HIV, the dendritic cells, grab these things up by endocytosis and present them to lysosomes, and they grind them up and turn them into peptides, and that's that. And then the T cells are informed. But at high inocula of HIV, that transport system becomes overwhelmed, and the endosomes make a passage from top to bottom of the dendritic cell, and actually are systematically exported to the other side of the dendritic cell and released again into the surrounding fluids. Now, the dendritic cell has now been signaling through cytokines, "Come hither, me lads, T cells, B cells," who are now attracted to dendritic cells and are now systematically being exposed to live-kicking HIV. And that is bad. And so you can see at high inocula, what you have is a systematic pass-off to the cells that are most vulnerable to HIV. And at a low inoculum, you have the completely opposite effect. And so it's not a huge leap of faith to imagine that this might be the same thing that's going on here in terms of, inhaling small concentrations of virus versus inhaling great big whopping concentrations of virus, and who gets sick. And it's not really a surprise to think that those who get highly exposed will go on to get pneumonia. I totally buy that premise. The one thing I quibbled with is that I don't think that the variolation metaphor that they use is at all apt, because when we're talking about variolation, we're not really talking about reducing the size of the exposure. We're talking about changing the route of the exposure.
Right.
Instead of inhaling smallpox viruses, which is why we call it variolation, we scratch it into the skin, into the vicinity of those same self-dendritic cells, who then grind up the smallpox virus and pass it off to the T cells and the B cells and lead to an immunizing event. Whereas if you inhale it, that's a totally different thing. Then you get viral pneumonia and disseminated smallpox disease, and 1 in 3 chances you're a goner. So I think their metaphor is wrong, even though the rest of their essay I totally bought.
Okay, so you buy the concept, maybe not the metaphor. Jess, what was your reaction to this one?
Yeah, this was a really interesting paper. I agree with Krish that I was a little initially thrown off by the metaphor, but then I definitely understand what they were getting at. I mean, I come to, from my professional training, I come to an understanding of masks through training in occupational health, epidemiology, and industrial hygiene, where we discuss masks and all kinds of PPE ad nauseum, which, PPE not being a term that I use in public discourse until fairly recently. Yeah. But so the idea of masks traditionally is that they are primarily a barrier when all other controls have failed. And so when every other attempt you have had as a collective workplace, for example, or in this context as a collective society, when your efforts to reduce the exposure have not been successful, the last thing you can do is to protect the individual. And you slap a mask on someone, you put a face shield on them. Physicians are wearing gloves in the context of treating patients with Ebola. They're wearing big suits. You're protecting the end recipient because efforts to control the environment are unsuccessful. And so I was thinking about this. And also in a political context where, we were talking briefly about the vice presidential debate or other, in terms of uptake of a vaccine and the politicization of a COVID vaccine. And is this an intervention that could potentially work in the event that 40% of Americans refuse to take an eventual vaccine? Mm-hmm. What are other, and so this made me think about, in a highly politicized context with the pandemic right now, are there interventions that may imperfectly work? This is not a perfect. There will still be people who wear a mask who are exposed to a small inoculum who get quite sick, right? This is not going to be in the same place in a work environment. There's, people who are wearing a mask and are inhaling asbestos at rates and at quantities that damage their lungs, for example. But is this something that comes in between a acceptance of a vaccine and doing nothing? And also mask wearing is highly politicized, as we see even in Massachusetts and even, especially in different parts of the country. And so that was kind of where this article led me, was thinking about this occupational health framework of hierarchy of controls. If you can't control the environment, you try to protect the end user. And then if the end user is not willing necessarily to, or doesn't trust interventions, what is something in between? And maybe that's a mask, or maybe a mask is even unacceptable.
I think that's a really great way to think about it. I would suspect, however, that anyone who is not willing to get a vaccine is probably also in the anti-mask camp. But I agree with your general point.
Right.
You all have kind of made the points that I wanted to make. The only one that I will add is, Chris, take your points completely, and you totally understand the science in a way that I just, I don't. But this strikes me as something that makes sense theoretically, but lots of things make sense to me theoretically and then don't necessarily bear out. So it's an interesting hypothesis to me. I'd want to see some actual data to back this up before I'm willing to say, I think this is what's going on.
Mm-hmm. Mm-hmm. But, it's a reminder to us that, we are... we act as if COVID-19 exposure is a binary phenomenon, and I suppose on one level it is, if you're going down to the level of 1 particle versus 0 particles of virus in the air, but that's not really the problem that we're facing. We're always dealing with a relative degree of exposure, and we know that. Even for an N95 mask, an N95 mask is not a N100% mask. It lets some particles through, and a cloth mask also lets some particles through. So it's like Jess says, it's not reducing your exposure necessarily to 0. It's reducing the dose of your exposure on a relative scale.
Yep.
Some air gets in through the sides, your nose peeks over the top. Similarly, we talk about an exposure as being 15 minutes within 6 foot of an individual. Well, that's a dichotomous disservice to humanity. That's the silliest thing I've ever heard. So if you left at 9 minutes and 59 seconds, you've got nothing to worry about. I mean, that is absolutely stupid. Yeah. So, it doesn't make any sense biologically. And so, of course, we're looking at a matter of a graded set of exposures. And therefore, I think this is a really powerful concept.
Yep. And dichotomania is real, my friend. It is real.
It is. Wait a minute. I was there. I left 1 minute in advance. Come on, people. Well, let's use our brains here.
All right. So I think we're all intrigued. Maybe want to see some data to back it up, but this one was a really interesting one.
Sure was.
So let's move on to our last segment, which is our amazing and amusing. And I'm going to go first because mine's a short one and it relates to SARS-CoV-2. I don't know if you all saw this article by Vasconcelos and colleagues from Brazil. It was a preprint that they put out looking at SARS-CoV-2, the work around SARS-CoV-2. There's been so much work around these epidemic modeling exercises that have been going on, particularly in the early days when we were trying to predict what the epidemic curve was going to look like for SARS-CoV-2. And then, suddenly there was all of this research being done, and not all of it was really necessarily being vetted. It was all being dumped. Dumped isn't the right word, but it was being put into the preprint literature and, varying degrees of quality, not peer-reviewed. It was then getting picked up in the media, and many of us were fretting about the fact that there was this information that was getting out into the world that really hadn't totally been vetted, particularly around these epidemic models. So what these researchers did, which I just thought was so, I guess meta is the term, is they did a modeling and epidemic growth study of preprints on COVID-19 and SARS-CoV-2. So they modeled the epidemic of SARS-COV-2. Now they did it obviously
it's like Google hits, right?
Exactly. This is tongue in cheek in a sense, but there's some really heavy math behind it that they put together, and then they've got this model that fits this giant rise in SARS-CoV-2 preprint work that starts coming out and fits this sort of beautiful epidemic curve over time.
Please tell me there's a lag function on this, at least for a couple of weeks.
Well, so what I will say is that the one piece of good news, if I read this correct, the one piece of good news seems to be that while there was exponential growth initially, there is looking like we may be getting to herd immunity on SARS-CoV-2 preprints. And so things do appear to be coming back down. But I thought that was pretty fun.
That is cool.
Chris, what do you got for us?
All right. So I also was thinking about COVID-19 epidemiology. There have been a lot of analyses and discussions about the so-called excess mortality associated with COVID-19. We're trying to figure out how many people died because of this horrible pandemic. And the total is not just the number of individuals who died with COVID-19, pneumonia, for example, but all the sort of, indirect deaths due to COVID-19, like, people with diabetes and hypertension who have a stroke 2 months later or, something like that. So they wouldn't necessarily go into the category of officially having died of COVID-19. But if you looked at the distribution of COVID-19 mortality, there's also a peak that's superimposed on that of officially non-COVID-19 mortality, which is presumably these indirect consequences. And I was trying to understand, what are the main drivers of that? And, was trolling the internet and trying to understand this. And most of the papers I found focused on the obvious sort of large major categories of death, like cardiovascular death and things like that, or kidney failure. And I didn't find that all very interesting because it was not very surprising. So I kept digging and eventually stumbled across two sort of relatively smaller causes of death, one very small cause of death influenced by the COVID-19 pandemic that I thought were surprising in different ways. And so the first one was lightning strike deaths. Lightning strike deaths are, would you guess, higher or lower?
Lower.
Since this is, yes, way lower, down by about a half, presumably because people are indoors.
And specifically, they're not on the golf course, or they weren't for a while.
That's right. They're not in places where you would get struck by lightning. I mean, there have been 16 so far this year. Usually there's around 25 to 30. And so it's a good year for not getting hit by lightning. So there's a silver lining there, I suppose, to COVID-19, that we're all hiding in our houses and not getting struck by lightning. So I thought that was interesting.
I thought that was super cool.
Yeah. The other one that I thought was interesting, which is a little bit less cool because it's more depressing, is motor vehicle accidents, deaths due to motor vehicle accidents.
I would have assumed those
up or down.
I would assume those went down too.
Yeah, that's would be my assumption.
And so you are right and you are wrong. You are right because the absolute numbers of deaths are down. Yes, that is true. you are wrong because the number of deaths per miles driven is way up.
Oh, interesting.
So there has been a drop because people are not in their cars, but when they're in their cars, they're driving like lunatics.
Okay, I have a question. Do you think that is because there are fewer cars on the road and therefore in urban areas people are driving faster?
I think so, because traffic jams protect you from dying of car crashes.
Yeah.
I've seen that in my neighborhood.
At 10 miles an hour.
Yeah.
But, I just I drive to BU once a week. And every time on the highway, I feel terrified because there's like lunatics passing me on the Mass Pike at 100 miles an hour on both sides, just zipping by.
Chris.
Because there's nothing to stop you.
Chris, I have apologized to you several times.
So the official statistic in terms of fatality rates per 100 million vehicle miles traveled, the VMT, last year this time, 2019, was 1.08 in the second quarter, and that's a number that has been largely constant for about a decade, and this year was 1.42.
That's
so
fascinating.
Not like a little bit up, way up.
Wow.
Even though the total number of deaths is a little bit down from last year.
Fascinating.
I've also wondered if there's, I have just had the same observational experiences where in my suburban neighborhood, especially early in the pandemic, not so much anymore, there'd be no cars and then there'd be someone like gunning it down a suburban street at like 60 or 70 miles an hour. And I have, in addition to driving fast when there are not people on the road, I've wondered too if there's a change in risk-taking behaviors in the context of being quarantined and isolated from others, and kids not going to school, people not going to work, especially early in the pandemic. If there, if like kind of a corollary is that people have to seek out experiences in other ways, and some people do that by driving too fast, and that would be borne out also in looking at other kinds of risk taking outcomes that relate to risk taking. And so I have definitely wondered that, how it affects, the sort of risk-taking behavior.
In this same report, which comes from the National Highway Traffic Safety Administration, so this is the Department of Transportation, basically, they did comment that alcohol and drug use as a cofactor in car crash deaths is also way up.
Mm.
So I think that is exactly what you're saying, right? It's driving insane and drunk without traffic jams as that buffer.
All right. Jess, what do you got for us?
Oh, gee. Well, I have something a little bit lighter, but also related to COVID. Oh, so a question for the ladies in the audience. Have you ever been out and about and you realize you're far from home and you forget your mask? And what are you going to do? So have no fear. Someone has developed, there's a patent, a bra that can be transformed in a few easy clicks into two fully functional face masks. So you and your friend or you and your partner, you whip off your brassiere, and all of a sudden you have two face masks that can be used to protect you, as we were just discussing, or lead to your own variolation, whatever it is. This is a product. This product recently won, the Ig Nobel Awards that come out, around the time of the Nobel Prizes. And so this was one of the top winners. It's called the EB bra. They have a range in price from $40 to $60, and a patented product. And there's a step-by-step procedure in terms of how you might transition your bra into a fully functional cloth mask in case you are just absolutely stuck, and that's what you got to do. So I thought that was very clever, served a need. Thank you very much. Her name is Elena Bodner, who developed this product, and more power to her.
Doesn't help the guys out there quite so much.
That's what I was going to say.
So much.
I forget my mask all the time, and so that's a really, really helpful little invention for it doesn't help me though.
Kind of leading the way in multi-purpose.
I was thinking,
clothing, accessories.
Could they do this with other male undergarments? But I think I don't even want to go there.
Yeah, I think we should leave that one for now. All right, so that is the end of our program. If you got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at PopHealthEX, or me at Prof. Matt Fox, or Chris at ID.Gill. Jess, I don't think you told us if you had a Twitter yet.
I'm not in the Twitterverse.
All right.
I admit, one day. I'm aspiring to be like the two of you. I'll make it there one day.
Well,
I don't tweet at all, so there's no aspiring at all.
Good point. Well, we want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound editing and being a cool cat and having the coolest cat wandering around in the background of his Zoom. Thanks for joining us. We hope you enjoyed it and hope you'll download our next episode.